Assalamu alaikum wa rahmatullahi wa barakatuh. So let's move on forwards to the interpretation of ECG. The third, so first and previously we have learned about the rate, rhythm, cardiac access determination and basic waveforms, segments and tones. Today we will learn about the further things. Okay. So first of all we'll learn about the chamber hypertrophy and atrial abnormalities. So let's begin with the name of Almighty. One point to remember before this is ECG criteria for hypertrophy are highly specific, more than 85%, but they are insensitive, 20 to 60, meaning approximately half of the cases. What that means? If you detect if the criteria for hypertrophy is detected in ECG, then definitely that hypertrophy is present. But many of the times, nearly half of the times, hypertrophy may be present, but the criteria may not be fulfilled in the ECG. That is the meaning of that. Okay, so it is not sensitive, but it is very much specific. Meaning hypertrophy may be present, but ECG may not detect that, and if it detects, then definitely it is present. So that one point we should remember. Okay, so first, atrial abnormalities. So right atrial abnormality. So we will have P pulmonale as we have discussed yesterday. What is P pulmonale? P wave height should be more than 2.5 small squares. Remember, it's like this: 2.5 small squares, or in the inferior leads, 2 3 AVF. In this 2 3 AF, the 2 is very much important. Okay, or it should be more than 3 small squares, or just remember 2.5 small squares more than this in the precordial leads, and in this precordial leads, V1 lead is very much important. So remember, for atrial hypertrophy, in all these leads, the lead V1, which leads we see, sorry, not one, lead 2, the rhythm strip, which is also known as the rhythm strip, and lead V1. These two strips are very important to know about P pulmonale or P mitral. P pulmonale indicates right atrial hypertrophy, and P mitral indicates left atrial hypertrophy. So next, left atrial abnormality, also known as P mitral. So here just there will be increase in amplitude. Okay, here there will be increase in amplitude. Here there will be increase in duration. Okay, and sometimes the P wave will be bifid like this. Okay, notch will be there in the P wave, and duration will be more than 3 small squares. Okay, in lead 2, or biphasic P wave will be P in V1, terminal negative will be more than 1 small square box. So that we will see in the image which is coming just after this. So P pulmonale indicates increased right atrial pressure or right atrial enlargement, and P mitral indicates P mitral is very much common because it is relating to the left atrial, left atrium. So it is very much common in hypertension and mitral stenosis. So there will be volume or pressure overload in these things in hypertension and mitral stenosis. So P pulmonale you will see. Okay, so that's about atrial abnormalities. So before going on to the left ventricular abnormalities, we see those things on the chart. Okay, see here. So as you can see here, so you take lead 2 and lead V1. Okay, normally, and you divide this P wave into two halves. Okay, two halves. This right half will be the right atrium, and this left half will be the left atrium. So, and in V1, normally if you divide this in lead V1, the P wave will be biphasic. The first half will be positive and the second half will be negative. So what happens in right atrial hypertrophy is the first half will be increasing the amplitude to more than 2.5 small squares. Okay, and in V1 what will happen? The second half will be negative if you compare to this to the baseline, but the first part of the V1, the positive part, will be enlarged. So what you see in 2 and V1, these things. So you will have a tall P wave in lead 2, and you will have the first first positive part of the V1 enlarged in right atrial hypertrophy. And what happens in the left atrial hypertrophy in lead 2? So first what will happen? The second part will get enlarged, but enlargement of the second part will not increase the amplitude. Instead, it increases the duration of the P wave to more than 2.5 small squares. Okay, that is in the lead 2. In lead 1, what will happen if you consider this as the baseline? Okay, so this second negative deflection will be increased. Negative deflection will be increased in V1. So that is seen in right and left hypertrophy. So right atrial overload may cause tall peak P waves in the limb or precordial leads. Left atrial abnormality may cause broad, often notched P waves. See here, it is a notched P wave. Notched P waves in the limb leads and a biphasic P wave in the lead V1 with a prominent negative component representing delayed depolarization of the LA. So remember, whenever there is hypertrophy, whether it is ventricular or atrial, the depolarization gets prolonged because the mass is increased. So depolarization gets prolonged. That's why these changes occur in the waves. Those are the changes in the atrial hypertrophy. And remember this in V1, in case of V1, this deflection should be more than one small square, either in the positive in right atrial hypertrophy or negative in the left hypertrophy. This should be more than one small square. Okay, that thing you should remember. Okay, so see here the ECG of P pulmonale. Okay, just search for lead 2. So this is the rhythm strip lead 2. You can see here tall P waves, and if I zoom this one still more, you can see this is one small box, this is second small box, this is third small box. So this is more than 3 small squares. Okay, that means there is amplitude of the P wave is increased, that is P pulmonale. P pulmonale. Okay, P pulmonale meaning there is right atrial abnormality, most probably right atrial hypertrophy. Okay, so this is, we have seen the lead 2. Now we will see the lead V1. See this lead V1. So this is the lead V1, and you can see here this is a biphasic wave. This is the negative component and this is the positive component. This is the negative component and this is the positive component. Normally these two will be equal to each other, but here you can see this positive component is increased and it is more than one small square. So that means there is right atrial hypertrophy. And one more thing we will know, see here the R complex. R is more than S in V1 and also in V1. That indicates there is also associated right ventricular hypertrophy also. We will know that in when we see that in ventricular hypertrophy. And you see this P mitrale here. So this is the second lead. Okay, so this is the P wave. So this is the notch, this is the right atrium, this is the left atrium. So this is notch, but notch it is not necessarily it will be present. Main thing which should be there for P mitral is the increased duration. You can see the duration, it is more than 2.5 small squares. It is more than 2.5 small squares. So that is in lead 2. In lead V1 you can see this is the biphasic wave. This is the biphasic wave, and as you can see this the negative deflection is increased more than one small square. So that means it is P mitral, which indicates left atrial abnormality or left atrial hypertrophy. Okay, now we'll go on to ventricular hypertrophy. Okay, see here. So left ventricular hypertrophy, to assess left ventricular hypertrophy, we have three criteria. Number one is voltage criteria. Three criteria. So in voltage criteria, there are two. One is Sokolow-Lyon criteria and second is Cornell criteria. Sokolow-Lyon criteria and Cornell criteria, that is voltage criteria. Third criteria is Romhilt Estes score. So we use a score because hypertrophy is not sensitive, it is not sensitive. We will not get many times. So we use a score to know whether definitely the hypertrophy is present or not. So if this Romhilt Estes score is equal to 5 points, just minimum it is equal to 5 points or more than that, then left ventricular hypertrophy is diagnostic. Or if it is equal to 4 points or more than equal to 4 points, then it is probable, maybe left ventricular hypertrophy may be present. So 4 point means probable, 5 point means diagnostic left ventricular hypertrophy. So what is the criteria say? So for voltage criteria, voltage means one among these two, Cornell or Sokolow. If these are present, it will indicate 3 points, which is not mentioned here. I am writing 3 points. STT changes, if they are present, they again indicate 3 points without digitalis. Okay. Left atrial abnormality, if it is present, again 3 points. Okay. Left axis deviation, if it is present, that indicates 2 points. Okay. QRS duration, if it is more than 0.09, nothing but more than 0.1, that is nothing but more than 1 large square, so again that carries 1 point. Okay. Prolonged intrinsicoid deflection, 1 point. Okay. Just remember the major points. What are those major points? Voltage, which carries 3 points. STT changes, nothing but strain pattern, we'll learn that. Okay. So 3 points carries 3 points. Left atrial abnormality carries 3 points. Left axis deviation carries 2 points. Okay. So if you get any of these two, any of these two, so any of these two, if it is present, means if the voltage criteria is associated with left atrial abnormality, if the voltage criteria is associated with left axis deviation, then left ventricular hypertrophy is definite. It is definite. Okay. No need to remember all these things. Just remember voltage with STT changes, voltage with left atrial abnormality, voltage with left axis deviation. If you remember that's all. Okay. So if any of these two are present, then that means definitely there is left ventricular hypertrophy. So that is Romhilt Estes score. What is Sokolow-Lyon number 1 voltage criteria, Sokolow-Lyon criteria? That says if the amplitude of S wave in V1 plus the amplitude of R wave in either V5 or V6 is equal to 35 mm or more than 35 mm, nothing but more than 35 small squares, then it indicates left ventricular hypertrophy. Okay. That is Sokolow-Lyon criteria. So just remember these things. So it is using V1, V5 and V6. This is important to remember. Okay. And the cutoff is 35. Okay. Now Cornell criteria. Second criteria is Cornell criteria. What does Cornell criteria says? So remember here, Cornell criteria uses AVL and V3. AVL and V3. Remember, Cornell criteria uses AVL and V3. AVL and V3. So if the R wave in AVL and S wave in V3 is more than 28 mm in men or more than 20 mm in women. So two cutoff points, 28 mm in men, 20 mm in women, then that indicates left ventricular hypertrophy. That is Cornell criteria. Okay, remember that. So Cornell uses AVL and V3 leads, and Sokolow-Lyon criteria uses V1, V5, V6. V1, V5, V6. Okay. Then what is strain pattern? This one you should. Strain pattern is, so ST segment depression and T wave inversion in lateral leads. Lateral leads are 1 AVL, V5, V6 with large R waves. ST segment depression with T wave inversion in lateral leads, and that what are those lateral leads? 1 AVL, V5. How you will remember? See, lead 1 is here, okay, and lead AVL is here, okay, and lead V5, V6 represent the left lateral part of the heart. So just remember like this. It is easy to remember. So 1 AVL, V5, V6 are the left lateral leads. They focus toward, they face towards the left ventricle. Okay. So if large R waves are associated with ST depression and T wave inversion, then that indicates strain pattern. And what is strain pattern? I have already discussed. Okay. Now we will see the LV hypertrophy ECGs. So these are from different books. Okay. This is from Harrison. See here. So when there is left ventricular hypertrophy, the mass of the left ventricle increases. See, V1 and V6. It is also using V1 increase. QRS in hypertrophy. Main QRS vector. So this is, sorry. So this is QRS and this is main QRS vector. So one thing to remember is whenever there is hypertrophy, that QRS vector will move towards mean QRS vector. The electrical axis will move towards that ventricle or atrium. Whenever there is hypertrophy, the mean QRS vector will move towards that hypertrophied ventricle. So this is the main QRS vector. So this is in the approximately at the level of lead to 60 degree. So when there is hypertrophy, see, it is having left axis deviation. Okay. Similarly, if there is right ventricular hypertrophy, there is right axis deviation you can see here. Okay, so normally in V1, I will remove this one. Normally in lead V1, the lead will be like this. Okay, and V6 will be like this. So prominent S wave in V1 and prominent R wave in V6. Okay, so when there is left ventricular hypertrophy, the prominency of this amplitude of this S wave will increase in V1 and amplitude of R wave will increase in V6. Okay, so if this V1 plus V6, or you can take V5 also, if it is more than 35, equal to 35 mm, that is left ventricular hypertrophy. Along with that, you will have left axis deviation. You can have left axis deviation. If left axis deviation is present, then hypertrophy is confirmed from the Romhilt Estes criteria. Okay, and in right ventricular hypertrophy, what you will see, so normally it is like this. R wave is very much short. It is RS pattern. S will be big, R will be small. R will be small, S will be big. But you see here in the right ventricular hypertrophy, R is becoming bigger than S. Or only R is there, S is not there. Or some small Q wave is there and R is there, but S is absent. So if S is prominent in V1, and if R is prominent in V1, I am saying as if R is prominent in V1, and normally in V6 you will not see any S wave, and you have some S wave here in V6. So if more important is the V1. So in V1, if R wave amplitude is more than the S wave amplitude, then that signifies right ventricular hypertrophy. So that you should remember. So left ventricular hypertrophy increases the amplitude of electrical forces directed to the left and posteriorly. In addition, repolarization with a prominent R wave. Right ventricular hypertrophy may shift the QRS vector to the right. This effect usually is associated with an RS or QR complex in lead V1. T wave inversions may be present in right precordial leads. That you should remember. So we will now learn about, because we have studied here right ventricular hypertrophy also. So we will see the criteria for right ventricular hypertrophy also here. So see here. So for right ventricular hypertrophy, you use two things: axis and voltage criteria. For right ventricular hypertrophy, you use two things: axis and voltage criteria. So right axis deviation should be there along with dominant R wave in V1. That means R should be either equal or more than S, either equal or more than S in V1, or R wave amplitude in V1 should be more than or equal to 6 mm with normal QRS duration. So there are two things. So you use axis and voltage combination to detect right ventricular hypertrophy. By that you will have two cutoffs. This is the number one cutoff, this is the number second cutoff. Number one cutoff says if the R wave amplitude is either equal or more than S wave in V1 along with right axis deviation, then that signifies right ventricular. If this is not present, you search for this one. You just see the amplitude of R wave in V1. If it is more than 6, if it is equal to or more than 6 with normal QRS duration, that means the QRS width should be normal, then that suggests right ventricular hypertrophy. Okay, that is about right ventricular hypertrophy. So you use axis and amplitude, means voltage criteria. Okay, so what are the associated findings? So you can have right ventricular strain pattern. So ST segment depression, T wave inversion in V1 and V2. Associated with right, you can have associated right atrial abnormality, deep S wave in lateral leads you can have. Now we will see these things in the ECG. See here. This is an ECG of right ventricular hypertrophy. Right ventricular hypertrophy. So what and all you are seeing here. First we will calculate first we will say the rhythm. See, the rhythm is regular. Okay, RR intervals are regular. Rhythm is regular and it is sinus because P waves are present and they are positive in 1 and 2. They are positive in 1 and each P wave is followed by the QRS complex. So that means the rhythm is regular and it is sinus. Now we'll calculate the rate. So rate is 300 divided by large boxes. So how many large boxes? 1, 2, 3 and 4 you can consider this as. So 300 divided by 4. 4 ones are 475. So 75 beats per minute is the heart rate in this ECG. Okay, and it is regular and it is sinus rhythm. Now next, we will look upon the P waves now. So how are the P waves? P waves are, you should look at the lead 2. They look, I will just zoom it in. Okay, So they are approximately, I cannot make out here. Approximately they are normal only. P waves are normal. They are not, duration is not prolonged and amplitude is also not raised. And in V1 also, but see here in V1 the positive part is increased more than 1 millimeter square, one small box. That means there is right atrial abnormality also. So there is right atrial abnormality also. Now we will see the ventricles. Okay. So ventricles, we will see axis also. So we have studied axis also, no? So you take V1, V1 is mostly negative and V3 is mostly, because this is biphasic we are not taking. Okay, so we will take 1, 3 and AVF also you can take. See, this is negative and this is positive and this is also positive. So this is reaching towards each other. So that means there is right axis deviation also. So there is right axis deviation, right axis deviation. Okay. Now we will see V1, V1. Okay, now we'll see, right? V1 we will see. See here in V1 you are seeing only R wave and there is no S wave. Okay, there you are seeing only R wave, there is no S wave, and along with that you are having ST segment depression along with inverted T wave. ST segment depression and along with inverted T wave. Here also you can see that there is notched R wave. That means the depolarization is prolonged, no, because of hypertrophy. The depolarization is prolonged. That's why there is notching in the QRS complex. You are having here R small s, R small s and R dash pattern. Okay, M pattern you can say. That means there is right bundle branch fork also. I think so. I don't know. There is right bundle branch fork. We'll see that later. Okay, so you are having the strain pattern also. So the V1 if you see here, V1 is mostly positive, R wave is mostly positive, and it is equal to 6 mm also, because one box is equal to 5 mm. It is going beyond one box. That means it is more than 6 mm. So both criteria are fulfilled. So there is mostly positive R wave along with right axis deviation, that confirms right ventricular hypertrophy. And if you don't take that, only if you measure the amplitude is more than 6 mm, that also indicates right ventricular hypertrophy. And along with that you are having a strain pattern also. And one thing you remember in strain pattern, always these limbs of the T wave are asymmetric. They are not equal. They are asymmetric. Asymmetric T wave inversion will be there in strain pattern. Asymmetric T wave inversion. If they are symmetric, no, then you should check. You should see the patient. If patient has symptoms, you should send for troponins. It can be infarction. Okay. Symmetric T waves, you should always rule out infarction. Okay. So in strain pattern, the T waves will be inverted, but they'll be asymmetric. Okay, so this is a very, what and all we have got here. There is right atrial abnormality, there is right ventricular hypertrophy, there is right axis deviation, heart rate is 75 beats per minute, regular rhythm. Okay, and it is sinus rhythm. Okay, these are all we have seen in this ECG. That is right ventricular hypertrophy. Now we will see for left ventricular hypertrophy. Okay, we will see for left ventricular hypertrophy. You see this ECG. This is the Cornell criteria for left ventricular hypertrophy. And remember, in Cornell criteria, we use AVL and S, AVL and V3, AVL and V3. So R wave in AVL and S wave in V3. So this is AVL. So you are saying the R wave, it is approximately 9 mm. Okay. Usually this AVL is actually, it is biphasic. Okay. Remember this one, it is biphasic. If you see a normal ECG, it will be biphasic, but it is positive in here. It is positive, mostly positive. So R wave in AVL is 9 mm and no, V3. And S wave in V3 means 20 mm. So plus this, so this is 29 mm. So that indicates voltage criteria is fulfilled. That indicates left ventricular hypertrophy. Left ventricular hypertrophy. And if you see along with that left ventricular hypertrophy. So this is in men, no? So men, it should be more than 28 mm, and in women it should be just more than 20 mm. So I think it is more than both 20 mm and 28 mm. So it is left ventricular hypertrophy. So how do you confirm that? Either you should have some STT changes. So you see if there is any STT changes. Yes, you can see here there is strain pattern, there is STT changes. So that will add 3 points. So 3 we got from the voltage criteria, 3 from this STT changes. So that confirms our left ventricular hypertrophy. Okay. Okay, so there is strain pattern also. Let us see whether there is left axis deviation also. Yes, we are also seeing here there is left axis deviation also. See here, V1 is predominantly positive and 3 is negative and AVF is positive. So either you can take this or you can take this. So based on this, they are leaving each other. That means left leaves. There is left axis deviation is also. So you can add again plus 2 for this. So you are having the Romhilt Estes score 3 plus 3 plus 2, that is 8. So it is confirmed. Okay. So that is you see in left ventricular hypertrophy. Cornell criteria you see AVL and V3. Now we will have this Sokolow-Lyon criteria V1, V5, V6. No, V1, V5, V6. Sokolow-Lyon criteria. Now we will assess first. Assess the regularity of the. So they are regular. See, you should always for regularity and for calculating the rate you should always see either the lead 2 or lead V1. They are known as rhythm strips. So you see the gap is regular. Okay, so it is regular. Now you see whether the p waves are there in 1 and 2. Yes, p waves are there and they are positive and they are followed by QRS complexes. Yes, they are followed by QRS. That means the ECG is regular and it is in sinus rhythm. Now we will calculate what is the heart rate. So see the boxes. So 1 2 3 4 5 and this constitutes 6. So 300 divided by 6, 6 1s are 6 5s are 30 50. So that is equal to 50. So 50 beats per minute, which is less than 60. So it is bradycardia. And what bradycardia? It is sinus bradycardia. Sinus bradycardia. It is sinus bradycardia. Okay, sinus bradycardia. So we have calculated the rate also. Now we will see whether there is some axis deviation. You are not seeing any axis deviation here. See, AF is also positive and 2 is also positive and 3 is also positive. That means the axis is not deviated. Okay, now after axis deviation, now we will see the main topic. Based on the patient, we will focus on the ECG. So we will see whether there is this Sokolow-Lyon criteria. We will see this here. So R in V1, S in V1, sorry, see this is 1 2 3 4, that means 20 mm. Okay, and S in V6, so this is V6, 1 2 3 and approximately 4. Here it is 20 mm. So 20 plus 20 is equal to 40 mm. So that is more than 35 mm. So the Sokolow-Lyon criteria is fulfilled. But what is our Romhilt Estes score? It is 3 still. It is 3. So we will see whether there is STT changes. Can you see any STT changes here? Can you see here STT changes? So you are not seeing any STT changes here. Okay, you are not seeing STT changes. Okay, whether can you see any P wave changes? Can you see any P wave changes? Okay, you see V1 V wave. No, you are not seeing P wave changes also. So that means we can say only we can say the Sokolow-Lyon criteria is fulfilled and the score for that is 3. So to say it as probable, at least we need 4 and definite at which we should have 5. Now one more thing, we will see Cornell criteria in this. Okay, Cornell criteria. Okay, Cornell criteria, we will see AVL. AVL is positive. See here how much it is, approximately 4 mm here. And V3 we will see S wave. So what is the S wave in V3? So what is the S wave in V3? So 1 2 3, so it is 15 mm. So 15 plus 4 is approximately, you can take it as 20 mm. Now if it is a female, then that Cornell criteria is fulfilled, and if it is a male, then Cornell criteria is not fulfilled. That's all. So but you can see here the Sokolow-Lyon criteria is fulfilled. Okay, so same thing here, same thing. And one more thing. Okay, that is left ventricular hypertrophy. One more thing I will add here. So I will add here one more thing. So normally if you see an ECG, in one you will have like this. In pre-coordinates I'm seeing V1, and in V2 you will have something like this. Sorry, I will cut everything. In V1 you will have like this, and V2 you will have like this. V3 approximately it will be biphasic like this. V4 will be same like this. As we will have V5, again you can take like this, and V6 only positive you can take. So what you are seeing, so one thing, this is the normal pattern. Now I will come here. So if there is left ventricular hypertrophy, no, when there is left ventricular hypertrophy, this will go on increasing. This S will go on, it will become like this. V1 will become uh, more like this. This will be enlarged very much. V2 will be slight negative, again it will be more positive. V3 will be more positive. V4 like this. That means this amplitude goes on increasing from V1 to V6 if there is left ventricular hypertrophy, that I mean to say. So just by seeing only ECG, so you can see here the same thing. See, the amplitudes are getting increased here in this. See how they are getting increased, how much they are normally. See here how much they are increased. So by seeing the ECG only, you can see there is left ventricular hypertrophy. Okay, so that is seen in left ventricular hypertrophy. In right ventricular hypertrophy, opposite will be there. The R will become prominent. R waves will become prominent and S will become prominent in V6. So same thing, an image depiction here. Okay, so Sokolow-Lyon criteria. So S wave in V1 and R wave in V4 V6 should be equal to less than or more than 35 mm, or you should have R wave more than equal to in AVL. AVL, this is one more thing we have learning here. So one more thing we are learning here, if only in AVL, if the R wave is more than or equal to 11 mm, that is also there in so one more additional thing we have learned here, more than 11 mm, then you will say it as left ventricular hypertrophy. Okay, then Cornell criteria, same thing. So you will see this is AVL, R wave in AVL, and S wave in V3. Okay, 28 mm in men and 20 mm in women. So that's about hypertrophy. Okay, that's all about atrial hypertrophy and ventricular hypertrophy we have learned, and I think this is enough for today. Already it is 38 minutes. So in the next class we will discuss about discuss the further topics like blocks. It is coming. Okay, thank you. We'll meet in the next video.